Hello, everyone. Welcome. I'm Philip James, and today's guest is Dr. Maria Papaleontiou from University of Michigan. Dr. Papaleontiou, welcome.
Thank you, Philip, and thank you for the invitation.
It's really nice to have you back. Last time we did an interview, it was for the podcast, and the topic was how thyroid cancer surgery, that the errors are 5 times greater than what is reported. And I want to just touch on that briefly, but before we do, for those listening and maybe they didn't hear your podcast yet, the previous podcast, can you share a little bit about your background and experience?
Sure. So, as Philip mentioned, my name is Maria Papaleontiou. I'm a physician scientist and adult endocrinologist at the University of Michigan. And my clinical and research focus is on thyroid disease, thyroid cancer, and particularly how thyroid cancer and disease outcomes affect older adults.
Mm-hmm. In your latest research, that's what we're talking about today, which is how thyroid cancer does affect older adults and how their treatment should be adjusted based on being diagnosed as an older adult. But before we dive into it, as I mentioned, that your previous podcast talked about how error is the result of thyroid cancer surgery is 5 times greater than what is reported. Can you give us a kind of a short summary about what that research is about?
Sure. So I think this was maybe 4 or 5 years ago that you and I discussed the paper that our team put out looking at postoperative complications following thyroid cancer surgery. And the main focus of that paper was to really assess these complications in a population-based cohort. So we wanted to really identify the rates of these complications and see whether these are comparable to what our surgeons or we actually discuss with our patients in the real world setting, and also identify at-risk populations that are more affected by these complications. We actually used a big database, which is called the Surveillance Epidemiology and End Results Medicare database for that study, which is representative of approximately 30% of the US population cancer patients. And we had looked at both general complications within 30 days and then thyroid surgery specific complications, such as low parathyroid function, which can lead to long-term low calcium levels, and also voice outcomes, specifically vocal cord paralysis. And that was within 1 year. So we actually studied approximately 28,000 patients who had undergone surgery for differentiated or medullary thyroid cancer. And what we found, as Philip nicely mentioned, was that approximately 6.5% of these patients developed general complications, things like postoperative fever, pneumonia, pulmonary embolism, which are common with other surgical procedures. But what was surprising was about 12% of our total population developed thyroid surgery-specific complications. And this was significantly higher in patients who were 65 and older, which is relevant to our podcast today, and also those who had higher comorbidities, so people who had more than 2 concurrent conditions in addition to thyroid cancer, and also those who had more advanced disease. And up to 23% so some of these complications occurred in up to 23% of patients, which is what you were mentioning, particularly those with comorbidities and the older adults. So this was a surprising finding for us, because usually we don't quote such high rates of complications in real life. And of course, this is dependent on the experience and expertise of the surgeon.
Well, when your research did come out that the error rate is 5 times higher, it was validating for a lot of thyroid cancer patients who had surgery and things didn't go really well, including me, who had a paralyzed vocal cord and compromised parathyroids and nerve damage and these other errors that I was told were such a low percentage. But then when we start going on these Facebook support groups for thyroid cancer,
Yeah.
we start to see that the number has to be higher. And in fact, it is. And
Yeah.
it was due to research like yours that I think is validating to thyroid cancer patients who had surgery
Yeah.
and things didn't work out well. So,
Sure. And I think what's important to note is that a lot of prior research had focused on academic centers and high volume surgeons. But we know in the United States, approximately 80% of thyroid surgeries do not happen by high volume surgeons. And definitely the surgical expertise is a directly correlates with obviously the complication rate. So our study was population based and included all surgeons. And I think that was what came out.
well, I think it's a great segue to talk about what we're talking about today, which is how does a thyroid cancer diagnosis affect somebody, an older adult? Because what we're really saying is that for the patients that maybe are told that, if you have thyroid cancer and have your thyroidectomy, don't worry about it. It's an easy surgery. Nothing's going to go wrong. You just take your little pill every morning and life goes on. But in fact, it's not the case. In your most recent research focuses on this. And let's start with the first thing here, which is what are the potential harms from thyroid cancer overdiagnosis?
Sure. And, I think you're right. And the way I think about it is, starting from the beginning for when a thyroid nodule is first identified. Because when you think about the diagnostic cascade for thyroid cancer, it really starts with the detection of a thyroid nodule. And we know that over the past decades, we have had increased use of imaging studies such as ultrasound, and we're detecting more thyroid nodules. And because most of these thyroid nodules are in older adults, we're finding more disease. So we know that despite the United States preventive task force recommending against thyroid cancer screening in the general population, we have actually gone completely the other way and have detected tons and tons of small nodules that may be low-risk thyroid cancers that, like you said, significantly can affect somebody's life. So I think, thinking about the beginning, where about 60% of all adults have thyroid nodules, and we know that the thyroid nodule incidence increases with age. But then when you think about the other side, it's about 70% of these nodules are benign. And then only about 10% end up being cancer, with the other 20% being indeterminate. So I think we have to start thinking even before the thyroid cancer diagnosis, do we need to be biopsying all these nodules? So, starting from the beginning, are some of these biopsies we're doing unwarranted because they yield, say a lot of papillary microcarcinomas, and treating those may be more harmful than beneficial in a lot of our older patients.
And Dr. Papaleontiou, I'm just doing the quick math that, okay, let's say 60% of adults have a thyroid nodule. Let's take the US population. That means we're talking about 200 million people have thyroid nodules. And then you said about 10% are
cancer.
Right. So now we're talking about 20 million Americans have thyroid cancer, and we really don't want them all knowing they have it. I mean, right?
Yeah. So, I think you probably know some of the literature, right? That prior studies prior to when we had such, sensitive imaging, we know that in up to 30% of patients that undergo autopsies who have died from a different reason, they're found to have thyroid cancer. So, it's sometimes called the prostate cancer of the neck, right? You're probably, a lot of people are bound to get it, but is it clinically meaningful to act on it? So, I think our group is very focused on decreasing low value care, and being very selective and individualized management for patients with thyroid disease in general, because not every patient is created equal, and not every thyroid nodular cancer is created equal. So we need to make sure we're doing the right thing for the right patient. So, and to go back to your question about potential harms, I think, as we already mentioned from the prior study, we know that, once you get to the thyroid cancer diagnosis, there's downstream harms. For example, higher risk of treatment complications, especially in our older adults, including surgical complications, which we have previously shown, as you mentioned, but also other things. There's been studies that have shown worse clinical outcomes after radioactive iodine, and also definitely from the TSH suppression therapy. So TSH suppression therapy, which is giving people thyroid hormone to make them hyperthyroid on purpose to decrease risk of recurrence, is warranted for high-risk cancers, but not for everyone. And in another recent paper, we've shown a lot of physicians do it unnecessarily for low-risk cancer and for long periods of time. And we know that that has adverse effects on both the cardiovascular system and the bone health. So once you diagnose something and you follow through with it, again, we have to think about the benefit versus harm. And then there's, like you mentioned, a lot of psychological distress and worry among patients, right? Because it's the C word and they want to get it out, and I can't blame them, because it's always how we present the information and how we discuss with each other. So we have to have a common goal when we're thinking about treatment. And we have to be mindful, I think, of, as you mentioned, the patient's preferences and the patient's values, because, in one of our other recent studies, when we looked at, thyroid cancer being labeled as good cancer, which we don't think that's appropriate. It's still cancer. So we think that invalidates the patient's feelings and worry about cancer. So we kind of have to find a nice balanced way to do this, in terms of, weigh the potential harms against the risk of missing a thyroid cancer that could be aggressive.
Yeah, a lot of it is, I think, how a patient learns about thyroid cancer. And they hear that word cancer and it is scary. But I think also you mentioned technology and how technology is exposing more thyroid nodules, and thyroid nodules that maybe would be harmless even if they have cancer for a patient. But with that being said, technology is also advancing quite a bit. You mentioned about profiling nodules and identifying aggressive thyroid cancers. Can you share a little more detail about that?
Sure. And when we think about, so one of the main things to know, going back in background for thyroid nodules and cancer in older adults, is that, as I mentioned, thyroid nodules are very common. But when you look at them overall, compared to younger adults, they have an overall lower risk of cancer. The problem is that with older adults, the cancers that are identified are more likely to be high risk, meaning anaplastic thyroid cancer, poorly differentiated thyroid cancers, or medullary. So we have to be careful about, sure, there's overdiagnosis, but we need to be able to identify these aggressive cancers because they could be life-threatening, right? And we need to act sooner than later. So I think again, we got to go back to the basics. Physicians need to inform this estimated risk for thyroid cancer. They have to think about clinical risk factors. So is there any family history of thyroid cancer? Is there a history of neck radiation? Things that would affect your thinking. And then also think about presentation. Was there an evolution of symptoms that, for example, a thyroid nodule has become big really fast and is causing neck pressure and difficulty swallowing? You're most suspicious, for example, for a poorly differentiated thyroid cancer. And also how we detect these cancers is helpful. For example, we know that, incidental thyroid nodules that light up on a PET scan are more likely to be cancer than in the general population. So about 1/3 of those nodules that are seen on PET scans usually have a higher risk of being cancer. And then, as you mentioned, we got to look at the ultrasound. So it is very important to have a very skilled person looking at the images once thyroid nodules are diagnosed. And we are firm believers in our institution that real-time bedside neck ultrasound is very important. So one thing that I do with my patients that I think is very appreciated, every visit we'll chat. I will have a look at their neck myself, because we can look at the images together in real time. We can talk about what's going on. I can explain what we think suspicious features may look like. And I think it's a very calming thing for patients to be able to do this in real time. So, and as you mentioned, there's different risk stratification systems that provide recommendations for fine needle aspiration, biopsy, etc. They're not perfect. They focus on obviously ultrasound characteristics. They leave out a lot of important things that we are trying to address, such as the patient comorbidities, the patient age, the patient preferences, etc. And I wanted to reference one study that was, I think, really stuck with me. This is Trevor Angel's study from California. And they had done a single institution study of a little bit over 1,000 patients who are 70 years and older. And they looked at all these people who underwent a biopsy for a thyroid nodule. And they found that 67% had a benign biopsies, which is very similar to what we would expect. And then of those that went to surgery, 45% had benign pathology.
Oh,
so
boy.
A lot of unnecessary surgery again, and only 17 out of thousands were diagnosed with a higher risk, life-threatening thyroid cancer. And when they went back and looked at these people who had the aggressive thyroid cancer on pathology, all of them had suspicious appearance on initial ultrasound. So going back to your question, you do need to have a skilled person looking at the whole picture to identify these cancers and try to avoid unnecessary surgery.
And there are a lot of people who choose to live with thyroid cancer if they have papillary thyroid cancer, and they're just fine, and they don't die from thyroid cancer. And I think that's a real mental barrier to break through, because sometimes I'll bring it up as a point of discussion when I'm talking to someone who's been diagnosed. I'll get an email from somebody listening to the podcast, and they just need someone to talk to.
Right.
And sometimes I will respond and say, yeah, I would take my thyroid back, even if it meant a few years less in my life, because I don't know how else to convey that when you don't have a thyroid, for many people, quality of life is damaged. And I think that's where your research is extra valuable for someone like me and many other thyroid cancer patients, to hear a medical professional saying, take 3 steps back, because this is a big picture to look at. And on that point, the more lethal thyroid cancers, if you can break the different types of thyroid cancer down and kind of explain how some are very dangerous.
Sure. And, and as I mentioned, I know this is probably a whole different talk, but anaplastic thyroid cancer, which typically we think arises from papillary thyroid cancer, but just de-differentiates. So it becomes less responsive to our typical treatments. And we know that it used to be typically seen in older patients as a rapidly enlarging thyroid mass. So these people typically will have very dramatic symptoms quickly. So they may notice a small lump, I don't know, early September, and then by mid-October, they have a massive thing on their neck. So the timeline of disease is important. And, unfortunately, it has the worst prognosis out of all the thyroid cancers. It's a small minority, but we don't want to miss that, because a lot of these are inoperable and they may require systemic treatments or palliative care. There's all sorts of reasons why, right? Something could become poorly differentiated. We do see it sometimes, again, typically in older patients, We do see cancers that sometimes present with distant metastases, so I would call that another aggressive form of thyroid cancer. It's not common, right? It's rare. And as you mentioned, that survival is really high for differentiated thyroid cancer, is 98%. But we also have to not miss that 2%. So I think these are the things that we need to make sure of. And then medullary thyroid cancer, which is a different kind of thyroid cancer that is sometimes associated with family history or genetic mutations. Can also be more aggressive, requires more extensive surgery and kind of a different approach. So these are not the most common forms of cancer, but they're cancers that we don't want to miss in a patient.
Throughout your most recent research about older adults and thyroid cancer, the term comorbidities comes up. Please explain a little further the relevance of comorbidities in older adults who are being diagnosed with thyroid cancer.
Sure. So comorbidities is a term we use in the medical world as the presence of two or more diseases in the same individual. So having concurrently two or more typically chronic diseases in the same person. And why it's important is because specific comorbidities can affect the way we think about treatment of, for example, thyroid cancer as we think here. One, as we mentioned, we know that they can significantly increase risk of complications. So we have found in our prior research that people with two or more comorbidities have a higher risk of surgical complications. Similarly, for example, if you think of somebody who has underlying cardiovascular disease or an arrhythmia, they may be more likely to develop adverse effects to TSH suppression therapy. The other thing we need to think about is that comorbidities can increase risk of non-thyroid cancer death. So, and they can shorten life expectancy. So we need to, again, go back and think about the whole picture to understand what the impact of this is when we're thinking about how far to go and how to personalize management, how to do the right thing for the right patient. And I think, a lot of prior studies had looked at number of comorbidities, but in our more recent study, we looked at specific comorbidities because we think the number alone doesn't always tell the whole story. Because if somebody, for example, has skin cancer and diabetes, is not the same as somebody who has stage 5 ovarian cancer and diabetes, for example. So the specific comorbidities do matter because they can shorten life expectancy, and then trying to treat a thyroid cancer that may not be lethal, as you mentioned, may not confer any kind of survival benefit to the patient.
I think it's the most recent research that you've done. It really, again, it is pushing thinking more critically around this topic because, and that is a paradigm shift. So just because a patient is diagnosed with the big C word, cancer, and there's usually a rush to get it out, including for the patient when they hear cancer. But now you're saying, wait a second, doing the surgery, is it really in your best interest? Is it really going to affect how long you live? Or, in fact, is it going to make your quality of life worse and shorten your life?
Mm-hmm. Yeah. And like I said, this is individualized, right? So for some people, surgery is the right answer, depending on the stage of their life and how they feel. And you have a lot of experience speaking with thyroid cancer survivors, and you know that we all have different personalities, right? So some people are more maximizers. They want everything to be done. They want to get it out. They don't care, about the consequences. And some people take a step back and say, well, maybe less is more. So, you're right. The research helps us guide, but there is a patient piece. So I think overall we do have to think about shared decision making based on the evidence and based on what we know, but also take into account what the patient thinks and wants too. But yeah.
Oh, go ahead.
No, you're fine. Yeah.
So I'm going to put you on the spot a little bit.
Okay.
Let's say your parents or one parent, a loved one, is diagnosed with papillary thyroid cancer.
Mhm.
um, how are you going to respond?
Yeah, so I think, assuming that there's no other concurrent health conditions and, quality of life is fine, um, diagnosis of papillary thyroid cancer, of course, there's not all papillary thyroid cancers are the same. So depending on whether there's regional spread to lymph nodes or not, or whether the thyroid cancer is confined to the thyroid, the options may differ, right? So if it's a small cancer, it's confined to the thyroid, active surveillance is an option,
Mhm.
right? Including a lobectomy. But if you do have thyroid cancer that spread, say, to the central or lateral lymph nodes, then I would definitely recommend surgery. So I think it kind of depends on the extent of disease. And the other thing is um, um, definitely try um, to send to a high volume center where there's experience with managing this. Um, so the options are there. Not every option is right for every cancer, right? But I think where we've come a long way, considering before the more recent guidelines from the ATA, everybody used to get a total thyroidectomy, right? So like 90% of people used to get a total
Mhm.
thyroidectomy. So now that we have lobectomy on the table or active surveillance, I think you're right. There is a paradigm shift. But again, we need to make sure that we're selective,
Mhm.
because you can also cause harm, right? So you need to think about harm both ways, doing too much or doing too little. So
And you talked about active surveillance, and now it seems like there's a lot of conversation around RFA. Also, is a treatment option.
right. So RFA, or radiofrequency ablation, is a non-invasive modality that's been used. Actually, was pioneered in Asia and Europe, and more emerging in the U.S. in the last few years. Particularly first for solid thyroid nodules that are benign. Um, Typically larger nodules, 3 centimeters or bigger for most centers, even though some centers will do it for 2 centimeter nodules.
Mhm.
And then there is, like you said, some research about using RFA to treat micropapillary thyroid cancer carcinomas. So just the really small cancers. There's some papers out that looked at isolated lymph node metastases as well. But and so I think it's definitely the way of the future. A lot of these ablative therapies that are non-surgical, right? So there's definitely pros, as you and I were talking before, that there's no surgical complications, there's no scar, it's not invasive, right? Um, but there's also cons. So, like we mentioned, not all nodules are created equal. So you have to think about complications of the procedure. For example, nodules that are more posterior and closer to the vocal cords may not be ideal. Or, you could still have side effects like skin burn and, bruising, etc. And there's always a risk of abuse, like any other thing. So we need to know we need to use judiciously. We need to identify patients that are candidates that would benefit. I think it's definitely something that's going to become more and more common as more research comes out from big academic centers showing safety and efficacy of this. And then the other thing, it's expensive. A lot of centers that are employing this now, it's an out-of-pocket cost for the patient. We don't have a great way of billing for these. So there's a lot of things that need to change also at the system level for this to become more acceptable. But I think it's part of what you were mentioning before. Wouldn't it be great if we could offer patients, well, you could do active, well, you're a candidate for X, Y, and Z, but you're a candidate for this, and then you have some more options. And like you said, I'm sure there's going to be an effect on quality of life.
As we near the end here, what is the one or two key takeaways you would like patients to have about your most recent research about diagnosing thyroid cancer in older adults?
So I think one of the main points I wanted to get through is really just look at the whole patient, think about potential benefits and potential risks before before going ahead to make a decision. Involve the patient in the decision making. Involve them. Talk to them. Hear what they have to say. Hear what their preferences are. Discuss their concerns. I think that's a really big piece. We need to put everything in a clinical context, but that context needs to include the patient's comorbidities. It needs to include the patient's preferences, patient's values. It needs to include life expectancy. It needs to include, are there competing causes of death other than thyroid cancer? And try to become more relevant, in clinical practice about shifting the focus of patient management to this more individualized treatment.
Great. Dr. Papaleontiou, thank you so much.
Thank you. It's a pleasure.